Which commissioners are on the phone?
Commissioner Khan.
Okay.
Commissioner Schneider.
Commissioner Peralta.
Okay. Terrific. I'll call the meeting to order. First agenda item is approval of minutes, including in your packet are the copies of the minutes from the May 21st public meeting. If there are no changes or correction, I'll entertain a motion for approval.
So moved. Commissioner Khan.
All right. I heard a second. Any discussion? All in favor? Aye. Any opposed?
Aye.
Minutes are approved. Commissioners, you've received the written updates from the centers. Ben, do you or any center directors have anything you'd like to add?
So, yes, thank you, Mr. Chairman. The Healthcare Commission had an educational retreat this morning dealing with our current budget and future budget priorities. The focus was on outlining where we stand in terms of spending levels and thinking about spending levels moving into fiscal year 2017. Commissioners provided their ideas and input, and the staff provided a broad overview of the process and where Commission expenditures are directed currently and in the future. Secondly, a note, somewhat not maybe for an executive director to note, but I wanted to point out as you leave our building to the right that we've put up a plaque of basically of every commissioner who's containing the names of every commissioner who's served. I think it reflects the staff's commitment to honor the service that our commissioners have made, but also I think it conveys our long-standing belief that there's a continuity to the work of the Commission that really has carried forward over 15 years now. I want to thank Bridget Zumbro for putting that together. It's a rather handsome display. You will note that we have some repeat performers on this on the plaque. Some people who have served previously, whose names are there as they are into their second term. We'll have to figure out how we finesse that for the future. But it is, I think, more important than anything else, the fact that we want to honor the continuity of the Maryland Healthcare Commission, and the membership over the years does show that. Thank you.
One, two, three, four. No center director update. Okay. All right. Of course. Come on up.
On the palliative care pilot work that we're doing, we presented information as an agenda item to you 3 months ago, so I don't want to take too much time, but wanted to let you guys know that we have given you some information in your packet about updates. So if you guys are particularly interested in this project, please do take a look at some of the slides that we presented to our advisory group on June 2nd regarding the data that we're assessing and evaluating for this to use in the final report. There's more information always on our webpage. The link is on the last page of those slides. But we are consolidating what we've learned from some national data collection and advocacy groups for palliative care, including the Center to Advance Palliative Care, the National Quality Forum, which developed some consensus recommendations for hospice and palliative care programs at this point. We're also going to be looking at 9 months of HSCRC inpatient data, looking at some adjusting for case mixes and lengths of stay and charges to make sure that we understand experiences of palliative care patients and those that were that had access to palliative care services compared to those that didn't. And so just very briefly and in summary, we're using these 38 preferred practices endorsed by the National Quality Forum for hospice care and palliative programs. And what they recently told us in our June 2nd meeting is that most of the literature and that National Quality Forum and groups like that focus on how to best provide hospice and palliative care to patients, which is obviously worthy and has a natural relationship. But what we're hearing from pilot hospitals is that they actually need to differentiate their services from hospice services. So you'll see probably a bit of that in the report, just to let you know. Please do take a look at it, and let us know if you have any questions, Linda Cole and myself or the staff on that. But we just wanted to give you a very brief update and not take too much time. It's not an agenda item today. Questions? No? Thanks.
And before Rebecca leaves, I'd like to be indulged for just a minute. Sadly, Rebecca is leaving us, so this will be
I thought he was kidding when you said you were going to.
This will be her last meeting
Yeah.
at the commission. Her husband has another job, which is taking her away from Baltimore. So after long thought, she decided she's going to go with him.
That's why they're throwing me up to you guys, I think, now.
It seems like just yesterday, but actually she's been with us for a couple of years now, and she's done fabulous work, and I just wanted to acknowledge that. She's done a great job leading, and hopefully she's going to help us, even though from a distance, finish up this hospital palliative care study. She did a great job last year on the rural health care study. She did a great job in CON, because that's where we started her out. She was lucky enough to escape to policy and planning, but everything we've given her, every challenge that we've given her, she's done a great job with, and I just wanted to acknowledge that and wish her well.
We appreciate the work you've done.
Thank you. You guys gave me a similar round of applause. I did my first commission meeting here, too. I haven't done anything yet, but thanks for that unexpected note. Let me know if you guys have any questions. I guess you'll hear from me, I guess, in the future anyway, even if you don't see me.
Sure sounds that way. Okay. All right, we're on to agenda item number 3, which is a certificate of need. Lorien Hartford, LLC, doing business as Hartford Nursing and Rehabilitation Center, has applied for a CON to construct a new 3-story, 70-bed comprehensive care facility in Forest Hill, Hartford County. Kevin McDonald, Chief of Certificate of Need, will present the staff recommendation.
Thank you. Good afternoon. Again, this is an application from Lorien Hartford 3 LLC to build a 70-bed nursing home in Forest Hill, Hartford County. The applicant is organized as a limited liability corporation and technically an independent entity with no parent company or subsidiaries. However, is an affiliate of Lorien Health Systems and 10 facilities operated by Lorien Health Systems. Other Lorien facilities in Hartford County include Lorien Riverside, which is a 129-bed facility, Lorien Bel Air, which is a combined nursing home and assisted living with 69 nursing home and 64 assisted living beds, and Lorien Bully Rock, a 78-bed nursing home facility. This project will be a 3-story project built on a 5.4-acre site. The estimated cost is $12,215,376. The expected financing is with $3.2 million in cash, $7.5 million mortgage, and working capital loans and loans for furniture, fixtures, and equipment, each at about $750,000. Looking at the need for the project, the county shows a net need for 97 more beds by 2016. And in addition to this project, MACC is now processing a CON application from another Lorien affiliate, Lorien Bel Air, to add 27 more beds to a CON that we approved last year that would add 21 beds there. We're hoping to bring that forward in July. Both of these applications came forward in response to MACC's publication of a corrected and updated need projection for Hartford County. Also relevant to need is the fact that the occupancy rates in the county are consistent, have been for at least 5 or 6 years, consistently among the highest in the state, in the low to mid-90s annually. In terms of looking at cost-effective alternatives, Lorien Bully Rock is a recently opened facility that's just ending its fill-up phase and is into its stabilization phase. Had it applied to add these beds, it would not have been eligible because it would not have met the facility occupancy rate of 90%, 2 years of occupancy at 90%. Lorien Riverside, the site was deemed unsuitable for expansion by the applicant, and adding all 97 beds to Bel Air was deemed inappropriate because of the size that would result in of 187 nursing home beds. In addition, due to the way that facility is built, it would have required an expansion of the assisted living, which is the first floor of that facility. In terms of viability and financial feasibility, resources seem to be there to implement the project. We have a letter of interest from Wells Fargo Bank indicating that there's an existing relationship with Lorien and an interest in financing this project, both the mortgage and the working capital and FF&E loans. Also have a letter from Michael Snarsky, a certified public accountant, stating that his knowledge of the applicant's finances is such that they do have the financial resources to provide the cash portion of the funding for the project. In looking at the ongoing feasibility, the applicant made reasonable assumptions on payer mix and occupancy and projects a positive bottom line by year 2. Looking at the project from the perspective of impact on other providers, staff feels that that will be minimal, given that this would add only about 9% to the existing inventory. And again, you have a county with an occupancy rate that has consistently been in the low to mid 90s. The criteria compliance with conditions of previous certificates of need. Although technically this is a new applicant because of the form of organization, staff feels it is really the intent of the criteria to consider the track record of its affiliate, if it's closely affiliated facilities and Lorien Health Systems. And over time, it has been a common practice for Lorien projects to make liberal use of the extension of performance requirements. There are 3 different performance requirements. Over the years, they've made liberal use of those performance requirements to stretch out the time that a project actually comes to fruition. However, they have ultimately complied with those performance requirements, but in many cases, he had a more lengthy implementation than expected. Also, an affiliate, Lorien Bel Air, opened in 2003 and failed to meet its minimum level of Medicaid participation. The facility opened in October of 2003 with 62 beds. The standard gives applicants 3 years to achieve their MOU requirement, although they need to be making progress, a good faith effort all along. Lorien did not meet the commitment within 3 years. In 2007, however, there was an update to the nursing home chapter of the state health plan, which changed the minimum participation level. It had been the average, the jurisdictional average. That was changed to 15.5% less than the jurisdictional average. Lorien was petitioned and was allowed to establish a new MOU complying with the new standard that was then in effect. And from that point forward, they have complied with the Medicaid participation rate. So while the applicant's performance on previous CONs has often involved delays and multiple requests for extending performance requirement, staff has concluded that on this criteria they have ultimately complied. And in view of the context of this situation where there's bed need in the jurisdiction, healthy occupancy rates, and no other potential applicant expressing an interest in filling that projected need, staff recommends that performance on this criterion be viewed as acceptable. Overall, the staff is recommending approval of this project. To recap the reasons for that, there is a projected need for 97 more beds in the county by 2016. And this facility would fill the need for 70 of those beds while broadening the geographic access within the county. As I've stated several times, the occupancy rate in the county is well above the 90% threshold, and the applicant has reasonably demonstrated that the proposed project is viable. The applicant is an experienced nursing home operator with a successful track record in nursing home operation. So staff concludes that the proposed project complies with the applicable standards in the state health plan as well as the criteria in our COMAR regulations, recommends approval with the following conditions. At the time of first use review, Lorien Harford Nursing and Rehabilitation Center shall provide the Commission with an executed memorandum of understanding with the Maryland Medical Assistance Program, agreeing to maintain the minimum proportion of Medicaid patient days required by Nursing Home Standard COMAR 1024-08-05A2. And I will remind the Commission that that is a standard, recommended condition for all of our nursing home certificates of need and not specific to this particular project. And that prior to first use review, Lorien Harford Nursing and Rehabilitation Center shall provide the Commission with information demonstrating that it has established collaborative relationships with other types of long-term care providers in Harford County to assure that each resident has access to the entire long-term care continuum, including its appropriate formal transfer and referral agreements. Here today, on behalf of the applicant, is Jim Forsythe, their counsel, and Mike Snarsky, CPA.
Thank you, Kevin. Can I get a motion to approve the CON? Second. Okay. Any questions or discussion? Try your mic.
There we go. $174,000 a bed. That jumped off the page at me when I was reading through this information. I thought that was pretty high, but I guess Lorien has pretty deep pockets to be able to make that fly, especially for a $12 million for a 70-bed facility. Really grabbed me. The other things that jumped out at me were that the projected Medicaid and Medicare occupancy levels project higher Medicare occupancy than Medicaid occupancy. That I haven't seen that anywhere. Almost 47% Medicare occupancy. That's very unusual. Almost over 2 times the regular average.
I think based on patient days, I think it was 50% for Medicaid. 50% Medicaid.
47.27% in year 1. Medicare as percent of total revenue. That kind of struck me when I read that. And Medicaid as percent of total revenue at 34.48. And I understand what you're saying there as far as Medicare revenue being a lot higher, but as far as per patient day reimbursement, but that just kind of jumped out at me. There's a couple observations right there. I mean, I operate a very similar size facility. I'm not sure I know I couldn't do that. So I had those observations.
Any responses by the applicant?
Yeah,
You can come up to the microphone, please. Thanks.
hopefully I won't be up here that long, but I think staff did a good job of reviewing the assumptions, and they are reasonable. Just off the top of my head, I think that the Medicare utilization, the number of patient days, I think you're a little high on that. That might be revenues.
Yeah.
Because of the substantially higher Medicare reimbursement. Maybe it's 34% and 50% Medicaid. Which,
Yeah, that'd be closer.
Yes. And that's entirely reasonable. And in fact, staff asked us to justify that. And
I would have too.
and it turns out to be what we do historically at the Lorien Bel Air facility, at a similar size prior to expansion. So it's not an optimistic projection on my client's part. It's in fact what my client actually does at Lorien Bel Air. Secondly, with respect to the Medicaid participation percentage, as you know, facilities are required to sign a MOU, which is a condition here, which binds them to serve the percentage, same percentage as other facilities in the jurisdiction for the particular county, and that right now is about 47-48%. So the 50% projection is in line with that, and also reflects operational experience at the Lorien Bel Air facility. Or CPA is here if you have any need for detail.
No, I mean, that's, the staff's good with it. I'm going to be good with it too. I just wanted to make those observations. I thought that
Yes, fair
kind
question.
of ambitious.
It's
And,
fair
it's
question.
located in a better part of the state.
But the
financially.
projections are, Mr. Snorsky's been doing these for a long time, and the commission has reviewed our projections in many other cases. The numbers aren't booked, and in this case, and in many others, they reflect our actual operating experience.
Thank you. We'll go counterclockwise. That's just
I'm similarly struggling with the button. The couple comments. This is an uncontested CON, correct?
Yes, sir.
So, how many? Can you give me an estimate of how many hours of your time and your staff's time was used in preparation for the CON application, above and beyond the regular work for the business plan? It's obviously necessary to come to a decision to build another facility.
I sit in on every aspect of project development and planning. I don't calculate it on my hours, but they're a substantial number. I believe my work involvement is not atypical, and as I think you are aware, and many others, I have to work with the architect, I have to work with the accountant, I have to work with the land scholar, I have to work with the commission staff, which over and above drafting the application also asks many questions on completeness and additional information. So I'm sorry I can't give you an exact number. I haven't billed for it yet. So I haven't added it up.
I'm trying to get a handle on the burden that we create with this process.
It is a substantial burden. It is not as substantial as when there are contested applicants, in which case it becomes a lawyer's relief act.
Yeah.
Is it hundreds of hours or thousands of hours?
Hundreds.
Okay.
For an uncontested nursing home CON, hundreds of hours.
Okay. And then there's follow-up,
Right.
because quarterly reports must be filed. When on occasion an issue comes up beyond an applicant's control, we present good cause shown to the executive director, who, when it's appropriate, will grant an extension, and all of that takes up stuff. Beyond the review process, the CON process itself is very lengthy and very demanding and very expensive. I'm nearing retirement age, and I'm not looking forward to it.
And from our standpoint, the health commission staff time, do you have a sense of how many hours that go in on our end in terms of reviewing this thing?
A project of this nature, Jim usually presents pretty complete applications. And so I would say relative to many, this one took less than most in terms of having to process. It'd be really hard. Since we have several people looking at it, I'd have to take
Sort
a
of
little
an unfair
time to
question
figure that
with
out.
It's
no
the same
preparation.
question, though. Dozens, hundreds, or thousands? Hours.
Dozens, more like between doing the analysis, the completeness review, writing the report, I would say maybe 25.
Thank you.
But that's really, I mean, if I really sat down, and I might come out a little different.
Understood. You won't be held to that.
In terms of the cost per bed, Commissioner, you know, I don't know that we've recently looked at cost per bed comparisons, but each facility is so different. But in terms of the Marshall evaluation system, this one did come in at lower than that evaluation system would project.
May I just add a note on this point? The state, as you may know, its reimbursement system has a capital cost ceiling. So if a provider desires to, it can spend more than that. My clients are local, family-owned and operated, and care about their name and focus a lot on quality physical plants, and so they routinely exceed their the state's capital cost, which means they're not being reimbursed for the extra money they spend, but they do it. Also, they build their own facilities, so what Kevin was referring to was basically a 14% savings for this project, as well as many others, over as compared to the Marshall and Evaluation Service guideline. So it's good value.
Fran?
Yeah. Kevin, do you have another point?
Fran,
Sure, go ahead.
I wanted to get back to Andy. We didn't get this across. It's actually a line item in the budget estimate of every CONM. It asks what the cost is. We summarized that budget, and that's why I was whispering to Kevin, because I wanted to see it, you know, actually there on our page. It looks like
What page?
summarize that. It's not in the staff report, but
Okay.
this is the full application budget estimate. CON consulting fee. And this is an estimate. These are all estimates. Yep. Jim pointed out he hasn't billed yet. But $15,000 is their estimate of, I think, non-legal consulting costs associated with developing the CON application. And they estimate total legal fees, which typically part of that CON, but some of it is sometimes other types of attorney's fees, $20,000. So at a high end, the estimate that this applicant actually provided us for the cost of this CON application is $35,000 out of a total uses of funds of $12.2 million. The other point I want to make, please, Fran, is that this Medicare assumption. For the last few years, everyone's chasing the Medicare dollars. I'm sure you realize. So we have seen some fairly what we think are pretty high assumptions on Medicare use, and we look at the experience of applicants, and it's not that unusual to see an applicant like this who can at least point to one or two of their facilities which has been successful in specializing in short-stay rehabilitative types of care and have gotten that percentage up. And so we have to give them the benefit of the doubt that they can perhaps replicate that situation. The ones who don't have evidence to that, we certainly require a sensitivity analysis. And we require them to basically rework their financial projections based on a more realistic assumption about Medicare. But year after year, we do see that proportion of total nursing home days going up. A few years ago, it was around 15%. It's now actually beginning to approach 20% statewide on average.
Yeah. And that's what I'm accustomed to seeing, and that's why I'd said that. I mean, I think at some point CMS will address that, and I think they have some preliminary planning and things in place to try to address that, because they see it. and they see the therapy utilization, et cetera, and they're going to try to control it. But that's probably at least 3 fiscal years away by the time it's done.
Can I add, you may have noticed that this project is strongly supported by Upper Chesapeake Health Center, and there's a letter of support from Lyle Sheldon, who points out his current working with our sister facility, Lorien Bel Air, which the Commission has been kind enough to recognize with a grant as partial funding for our telemedicine pilot project we're currently undertaking, hopefully to reduce unnecessary hospitalizations, admissions, and readmissions to the healthcare system, all in line with the new reimbursement waiver. We're strong supporters of that. The file contains Mr. Sheldon's letter of support and indicates he's looking forward to further collaborative efforts at this new facility. I'm not at liberty to disclose internal discussion, but one of the reasons, and the reason I mention this is because we expect Medicare utilization will continue to be strong at this new facility as a result of collaborative efforts with the hospital system. As you know, it is in the hospital's interest to reduce admissions in the brave new world of the new waiver, and we are working and expect this new facility will play an integral part in that, effectuating that new state policy.
Thank you. I will try for the third time.
May I ask a question, Mr. Chair? Thank you. Kevin, thank you for this analysis. And my question has to do with the quality standards. There's been a lot of discussion about the sister facilities, the affiliated nursing homes in the Lorien family of nursing homes, and how in some instances they have relevance to this review, and then in other standards laid out in the analysis, it looks like they don't. So specifically, my question is on the standard on page 13, the quality standard, which requires that the applicant demonstrate that it has no outstanding level G or higher deficiencies, and that it has maintains a demonstrated program of quality assurance. So in your analysis, Kevin, you said that that doesn't apply because this is a new facility. So what I'd like to ask the applicant, if in the family of the sister facilities, is there a history of this level G or higher deficiencies in terms of the quality standard?
I don't recall whether any of the Lorien facilities has had a level G. I'm sure they must have over the course of 20-plus years, but nothing springs to mind. I recall staff entered the finding that it did in this case because this isn't an existing facility. Each facility is a little different, as I'm sure you appreciate, insofar as they may be serving different patient populations. But the facility does maintain a quality assurance program and has a vice president for clinical services who travels.
Can you just help me out understand where one would look to see if there was a level G quality deficiency? Where?
And I can help with that. And first, I want to apologize for that inconsistency, because I think my understanding of those criteria, and I think the staff's understanding of those criteria, is evolving in terms of, as you may know, the nursing home industry has, I would say, it's an understatement to say complex organizational structures, basically to provide insulation, in my view. But I think going forward, whenever we have a situation like this where there are affiliates, we're going to treat that as if it's the applicant. I think we've had some, pushback from applicants over time, maintaining that that's inconsistent with our standards and criteria. But I think we've had some internal discussions and decided that no, the intent of the criteria and standards is that we do that going forward. And I do have the answer for you, because I got that question from another commissioner earlier. And I looked at all of the Lorien nursing homes in terms of their last, I can't tell you historically going however far back. I can tell you that in all of their currently operating facilities in the latest health inspection, they have no G or higher. And just kind of eyeballing these numbers, their deficiencies range anywhere from 1 to 15 with eyeballing it, the average is probably about 6, and the Maryland average number of deficiencies on a health survey is 11. So just, a snapshot of each of these facilities' latest health inspections. They appear to be collectively well above average, at least in terms of number of deficiencies. Now, one deficiency, well,
Yeah,
that's why
level,
the G are higher.
I'm just not understanding. Level G, is that?
There's no level Gs.
Family operated.
Any questions?
I have one. Kevin, this is for you. The Medicaid participation rate is it's a standardized requirement, correct?
It's a requirement,
It's
yes.
based on local geographic areas, right? So in other words, one in Baltimore City would be different, let's say, from Cecil County or Anne Arundel.
Correct. It's based on the average of all the facilities in the jurisdiction, less 15.5%.
All right. Is that a state requirement for nursing homes, or is that a federal requirement?
I believe that's a Maryland requirement.
There's a Maryland requirement. Okay. Do you have it off the top of your head? Do you have an idea what the average is in the state participation? Putting them all together.
Linda Cole probably would be more accurate than that.
I mean, just ballpark.
I know that the average before the adjustment was about 60, 62%.
All right.
So it would be minus the 15 we talked about around 50.
Right.
It's been fairly consistent, and it's something that we worked on years ago jointly with the state Medicaid program to make sure that there was access for Medicaid patients in any facility that we approved.
Okay. Thank you very much.
Any questions on the phone? For any commissioners on the phone have questions? Okay. If not, all in favor? Aye. Any opposed or abstention? You have your CON.
Thank you. Thank you all.
On to agenda item number 4. Seasons Hospice and Palliative Care of Maryland has applied for an exemption from CON for its proposed merger with Optum Palliative and Hospice Care. And Kevin, who will present that bill will present the staff recommendation.
Excuse me, Chairman Daniel and Commissioners. Good afternoon. I'd like to present before you a request for an exemption from Certificate of Need Review. Seasons Hospice and Palliative Care of Maryland is a general hospice program seeking exemption from Certificate of Need Review as a result of a proposed merger with Optum Palliative and Hospice Care. Seasons currently operates as a general hospice program serving 8 jurisdictions that include Baltimore City and the counties of Anne Arundel, Baltimore, Carroll, Cecil, Hartford, Howard, and Prince George's. Seasons proposes to purchase and merge its operations with Optum, who is authorized to provide general hospice services in 3 jurisdictions, which are Baltimore, Montgomery, and Prince George's counties. Under the terms of the agreement, Seasons will combine Optum's Baltimore and Prince George's County hospice programs with Seasons' existing program and expand its operations to include Montgomery County. Optum will cease operations as a general hospice program in Maryland with the closure of this merger. The objective of this transaction is the merger of the 2 hospices, with Seasons continuing to serve these 8 jurisdictions as a general hospice program and adding Montgomery County to its authorized service area. Meeting this objective requires considering this transaction as a merger of 2 healthcare facilities, given that Seasons has not received authorization to serve Montgomery County. Expanding the number of jurisdictions served by general hospice requires Commission approval, either through a CON or in this case through an exemption from CON review. The Commission's regulations at COMAR 10.24.01.04a may exempt from Certificate of Need Review certain actions proposed by a healthcare facility or merged asset system comprised of 2 or more healthcare facilities. Among these actions eligible for exemption from CON review is the merger or consolidation of two existing hospice programs. In order to meet the requirements of this exemption, paragraph 104B requires that facilities organizations must give the Commission a 45-day written notice of their intent to merge or consolidate. Seasons provided written notice on March 19, 2015, with the anticipated closing of the transaction by no later than August 1, 2015. This merger will not involve any renovation or new construction to an existing facility, the relocation or reconfiguration of existing medical services, or a change in bed capacity. There is no outstanding public body obligations associated with these facilities. On April 24, 2015, staff requested publication of notices of receipt for the exemption request in the Baltimore Sun and Washington Times, as well as in the Maryland Register on May 15, 2015. No comments were received. The regulation at paragraph 0.04E directs the Commission to issue a determination of exemption from CON review if the merged asset system has provided the required information and the Commission finds that the proposed action, A, is in the public interest, B, is not consistent with the state health plan, and C, when it will result in more efficient and effective delivery of health services. With regard to public interest, Seasons states that the merger with Optum will enable the residents of Montgomery County to benefit from its broad experience in existing systems and infrastructure as a hospice provider, allow Seasons to operate more efficiently by closing Optum's office in Elkridge, allow Seasons to reduce fixed costs and spread overhead costs over a larger volume of patients served. Seasons also envisions improved staff productivity through increased numbers of patients seen per staff member. The merger will not have a significant impact on consumer choice, since a total of 10 hospices will continue to operate in Baltimore County, 12 in Montgomery County, and 11 in Prince George's County after the merger is completed. With respect to the 3 counties affected by this merger, Seasons has significant market share in only one jurisdiction, which is Baltimore City. Merging with Optum will not dramatically increase Seasons' market share in this jurisdiction or in Prince George's County. Historically, Optum has a small market share in Montgomery County, and as a result, Seasons will not be acquiring a major hospice provider serving this jurisdiction. And then finally, since Medicare is a major payer for hospice services, the merger will not have an impact on the charges paid for hospice care by the vast majority of hospice patients. So with regard to the review of the state health plan, staff reviewed the standards for hospice services under COMAR 10.24.13 and found that Seasons' merger is not inconsistent with the applicable state health plan. Finally, in addressing the delivery of more efficient and effective healthcare services, Seasons states that as one of the larger hospice providers authorized to serve Baltimore County and Prince George's County, it can easily expand its program to include Montgomery County in an efficient and effective manner. Seasons will keep its office open in Glen Burnie and close Optum's office in Elkridge, reducing administrative costs. Therefore, in conclusion, staff recommends that the Commission approve the request for an exemption from CON review for the merger of the hospice programs of Seasons and Optum. With this exemption, Seasons as the surviving entity will acquire authority to provide hospice care to the residents of Montgomery County. And then with that, I would like to introduce the following representatives on behalf of Seasons Hospice and Palliative Care. Mr. Dean Foreman, who's the Executive Director, Howard Solins, who's the Counsel, and then Andy Solberg, Consultant. And I'm here to answer any questions you may have.
All right. Thank you, Bill. Can I get a motion to approve the exemption for CON review? Motion. Second? Second? Okay. Any questions or discussion? Start this way and work around here. Okay, Diane?
So I'm interested in understanding the available array of hospice services in each county. And I noticed that Seasons does not provide pediatric hospice services. So in all the counties that Seasons serves, are there other hospice service providers that do care for pediatric patients?
Sure to turn on the mic.
Good afternoon. You're specifically talking about the 3 jurisdictions
3 jurisdictions.
Actually, I'm interested in any jurisdiction, but
So sure. I mean, in the jurisdictions that we serve, Hospice at Chesapeake has a pediatric program in Arundel County. Gilchrist has a rather established pediatric program in conjunction with their geographic footprint. I believe that the Hospice of Montgomery County, Ann's program, has a pediatric.
So let me flip the question around so it's more pointed. Is there any area that would result in not having the full age spectrum have access to hospice services when this merger happens? There
would be no difference with this acquisition merger than it is today. I don't believe there's any unserved continuum from pediatrics through geriatrics that's not served in the state at this point in time.
Okay.
I can't speak to every provider across.
No. But the areas that Season serves is what I'm interested in.
Correct. No change.
Any other questions? Yes, Ben.
Thank you, Mr. Chairman. So as you're aware, we've had a work group to engage hospices in initiatives to reach out to minority populations. Certainly Montgomery County, I think, is the jurisdiction with the 4th or 5th highest percentage of minority residents. Maybe you could tell the Commission what programs you would plan to establish beyond what Optum has in place already.
Thank you for the question. Good question. I think, I mean, basically, Seasons as an organization has invested heavily in Baltimore City and PG County with faith-based communities, the Department of Aging. We brought in consultative services to help us across that spectrum with education and broadening knowledge and acceptance of end-of-life care. I would anticipate that we would expand that same energy or platform into Montgomery County and duplicate what we're doing in PG and Baltimore City.
We provided, in past CON reviews, we provided some specific data, and Seasons has among the highest diversity penetration of any hospices in the state. They'll bring that Baltimore City experience to Montgomery County.
So that's great to hear. One of the other things that caught my eye is it appears that Seasons provides less than the state average of total patient days as charity care, and I would assume that there may be some correlation there. So I'm curious as to why the charity care is lower than the state average, and then also any efforts that you're engaging in to improve that.
Sure. Interesting data, and my explanation of that, I mean, that really starts out with our policies and procedures at time of admission. So there's no patient that's denied access or admission to hospice based on ability to pay. All patients are evaluated on medical and eligibility criteria, of which financial is not a factor. We work with, as Mr. Solomons indicated, the entire community. We served aggressively underserved populations. We work with most, if not all, of the hospitals in inner city Baltimore. And I believe that we're relatively aggressive with providing care across the entire community. I can tell you that I don't know what my competition does in the market. I can tell you that Seasons, both locally and in our national office in Rosemont, Illinois, we have teams of folks that work with patients and families to find payer sources. So we work aggressively with our policies to find a payer. We're relatively good at that. We may be more aggressive with those resources, and that may be some criteria or logic as to why Seasons charity care is below the state average. I could tell you that I approve charity care, if not daily, almost weekly. And it's just a part of what we do. But once we do that, we commit resources to find a payer source.
Okay.
Commissioner Peralta has a question.
Hold on one second. We'll let Dr. Moffitt go, and then
Sure.
Dr. Peralta. Okay.
Could you tell me, in terms of the breakdown of revenues, could you give me some kind of a breakdown as opposed to public or private funding for hospice care in your facilities?
So hospice,
roughly.
Yeah, hospice is 85%, 88% Medicare. Medicare.
How about Medicare? Oh, okay, Medicare.
Probably 8 to 10% Medicaid, small percentage of commercial payers, and then charity.
Dr. Peralta?
Thank you. I have a question related to the diversity issue, and in particular in Montgomery County, there is a large population of non-English speaking. Usually those patients hardly get to use the services, and I'm wondering how or what efforts are you making in terms of educating the providers and the community leaders and others in other languages, but at the same time it's serving that the patients and families in your institution in terms of speaking on the other languages. And it comes to my mind Spanish-speaking, Vietnamese, and others. Thank you.
Excellent question. So what we're learning now and what we have learned is that with the Optum acquisition came an opportunity to onboard some of their team members, but certainly at the information level, the consents, the admission packets, we do those both in English and Spanish. We aggressively pursue and try to hire on each one of our care teams. We have 6 that encompass the market, bilingual staff. In this particular, in several cases, we have nurses and/or social workers and/or chaplains that are bilingual, and we use them obviously in direct patient care as well as community education events. I will acknowledge that the area of opportunity there is direct education within the Spanish community, the minority community, to have a voice and educate and do something very similar to what we're doing in the underserved communities of Baltimore City and PG County.
The other thing I would add is this is, as was indicated by Mr. Chan, not a CON application. It's an exemption based on increased efficiency. Optum is a very small hospice, and its ability to leverage its resources to address the kinds of issues that Commissioner Peralta was talking about will be improved here, because by having a hospice which is also providing services in Prince George's County, you reach all across the population. I know from other work that we do that it's in addition to the Asian community and the Hispanic community, there are large populations of Native African communities from different countries and cultures, which are very different from each other. And so I think that Seasons being able to bring its scale is going to allow us to bring in these additional resources in a better way.
I would just add one additional thing. We subcontract with a service. I'm drawing a blank on the word, but we subcontract with a service that provides us translation services if we're in need of a specific situation where we have to be able to communicate in a certain language.
Any other questions from commissioners on the phone? If not, let's move to a vote. All in favor? Aye. Any opposed? And abstentions for the record, myself and Commissioner Flagg. You have your approval.
Thank you.
Thank you.
I'd like to thank the staff for all their work on this, and appreciate it very much.
I've had a little more time to do my mental math. I want to give you another answer. There are a number of hands that get on one of those reviews, and I probably wasn't taking everybody into account. I think on that review it was probably closer to 50 to 75
hours. Okay. Thank you. All right, let's move to agenda item number 5. I think there is a separate document here for plans for development of the state plan for freestanding medical facilities. Paul Parker and Kathleen Rubin are going to present a summary of the plans for the development of a new chapter of the state health plan that will, if adopted, regulate the establishment of freestanding medical facilities. Paul and Kathleen.
Chairman Tanio, members of the commission, good afternoon. To my right, Kathleen Rubin. She's an acute care planning and policy analyst and has been working far more than 75 hours in recent months on developing a new state health plan chapter. About 10 years ago, the state of Maryland created a new category of healthcare facility, the freestanding medical facility. She's going to give you some background on that, and then I'm going to speak briefly about where we are in terms of our efforts to develop a new state health plan. I guess from some perspectives, the bad news is that this is going to be a healthcare facility that's regulated under certificate of need. It has been operated as a pilot type of program to date, so actually statute has controlled the number of facilities developed in the state, but on July 1st, they're setting them loose, and so there will be an ability under state law to apply for and receive certificate of need approval to establish these types of facilities. Through our scheduling, we are putting off the beginning of that until 2016, but what we're trying to do is put in place some guidance for the commission to use in those types of reviews. So I'll turn it over to Kathleen now to give you some background, and then again I will talk a little bit about the plan that we've been drafting.
Great, thank you very much, Paul. Chairman Tanio, commissioners, good afternoon. We are going to discuss the development of new state health plan regulations for freestanding medical facilities. But before I begin, I want to clarify that term, freestanding medical facilities, because in other states, the same type of facility is often called a freestanding emergency center or a freestanding emergency department or even a satellite emergency center. So you're going to hear different terminology as we go through this presentation. I'm going to give you an overview of what we're going to talk about. I'm going to start with an explanation of freestanding emergency centers in general, what they are, why they were originally established, and then we'll discuss Maryland's version, the freestanding medical facility, talking a little bit about some of the regulations that they must follow, and I'm going to talk very briefly about the pilot program. And then Paul is going to take over, and he's going to discuss the basic framework for freestanding medical facility development and discuss some of the relevant project review standards to be included in the state health plan. And then finally, I'm going to talk about what our next steps are in this process. So freestanding emergency centers are described by the American College of Emergency Physicians as facilities that can either be independently owned and operated or act as satellite of hospital, like an outpatient department. So these facilities would be structurally separate from the hospital, but they would function very much as part of the hospital. Both of these models, however, do provide unscheduled outpatient services to individuals. And these facilities fill a gap on the spectrum of emergency medical services between the hospital, emergency department, and the urgent care center or primary care physician office. So they do have the capacity to provide life-saving and emergency care, but they, like a lot of hospital emergency departments are often utilized by patients that have low acuity medical needs, and they could possibly be served in a different type of facility. So freestanding emergency centers were initially established to provide for emergency care needs in rural and underserved areas, but more recently they're used as a vehicle for reducing significant overcrowding in hospitals. In Maryland, the freestanding medical facility does operate as a satellite outpatient department, so they're part of an affiliated hospital. They are, however, separately and distinctly licensed healthcare facilities that provide this unscheduled outpatient care, compared, for example, to Virginia, where there's just one license for the hospital, and this freestanding emergency center is covered by the hospital license. So in Maryland, regulations state that the freestanding medical facilities must be open 24 hours a day, 7 days a week. They are subject to the Emergency Medical Treatment and Active Labor Act, in that they must provide emergency health care treatment to anyone needing it, regardless of their citizenship or legal status or ability to pay. They're also required to provide certain services. So, for example, they must have an on-site laboratory service, radiology service, and either an on-site pharmacy, or they have to contract with a pharmacy that provides 24-hour service. They also have to have prearranged transfer agreements with facilities that can provide care for patients if they're indeed admitted to the hospital. These facilities also have to have required staffing, and that includes a full-time administrator, a medical director who is a licensed physician and board certified or eligible in emergency medicine. And they also have to have other personnel, at least one physician trained in emergency medicine, sufficient registered nurses, other professionals, certified radiation technologists, laboratory technicians, so enough staff to run the facility. They're required to have certain kinds of equipment, and that equipment is that's required by the Centers for Medicare and Medicaid Services, and then it includes a variety of small equipment and large equipment, stethoscopes, suture trays, orthopedic equipment, and then some larger like cardiac monitors, EKG machines, and there's a whole list of required kinds of equipment. So in Montgomery County, in Maryland, there are 3 freestanding medical facilities, and those are highlighted in red on the screen. The first 2 that are listed here are part of Maryland's pilot project on freestanding medical facilities. Legislation enacted by the Maryland General Assembly directed the Maryland Healthcare Commission to conduct this pilot study of the operations, utilization, and financial performance of the freestanding medical facilities. So the Germantown Emergency Center was one of the pilot sites, and that was established by Adventist Healthcare Shady Grove Medical Center in 2006. Also the Queen Anne's Emergency Center, which was established by the University of Maryland Medical Center's the Shore Medical Center at Easton in 2010. And both of these freestanding medical facilities were established to improve access to care, but for very different reasons. In Germantown, which is part of Montgomery County, the center was established to reduce the overcrowding at Shady Grove Adventist Hospital. And the Queen Anne's Emergency Center was established because there are no hospitals in Queen Anne's County. And the nearest hospital is across the Bay Bridge, which is subject to heavy congestion, traffic congestion. The third that's listed here, the Bowie Health Center, is not a pilot, but it is licensed as a freestanding medical facility, and it's been operational since 1979. So the pilot period in Maryland ends in 2015, and going forward, freestanding medical facility development will be subject to Certificate of Need regulation. So in developing the state health plan, these are some of the inputs that we use to develop the preliminary state health plan. The statute, the licensure and regulations, and we also use data from the mandated pilot studies that we have already discussed. And we did an extensive literature review on emergency departments and on freestanding medical facilities. We also looked at the policies and standards that were developed nationally and by other states, since we can often learn a lot from the experiences of other states. Yet in this case, a lot of states did not have, well, some states didn't even have this type of facility in their state, and they don't have a licensure category for this, for freestanding emergency departments. For other states, the freestanding emergency department is considered a part of and is licensed by the hospital. And there's just a few states that have developed a state health plan or something very specific for freestanding emergency centers. So there are relatively few benchmarks, and others, we do have them for emergency departments, but not for this type of facility. So Paul is now going to discuss the basic framework for freestanding medical facilities.
The reason we're here today is because within the next couple of weeks, we're planning to post a draft state health plan chapter for FMFs on our website and seek informal review and comment from the hospital industry. Only hospitals will be allowed to develop these facilities. And we're using a somewhat different process here than we typically use to update state medical facilities plans chapters. This is a new chapter. And so rather than forming a work group initially to spend time actually helping staff develop a first draft, we're developing a first draft, and we plan to have a work group meet probably within a few weeks after we post and get comments on this draft plan, and provide us with input on how we should modify the plan if necessary, and also give us some feedback on the different comments we've gotten. So in terms of a basic framework in the draft plan that you'll be seeing, we are, I think, taking a fairly conservative approach in outlining how we want to see the pattern of development proceed in Maryland. We're going to be proposing that freestanding medical facilities be established in parent hospital primary service areas. These are the areas from which the hospital would be drawing 60% of its patients. We're also proposing that establishment of freestanding medical facilities should be justified in one of two ways only. They should be justified on the basis of overcrowding at the parent hospital ER or the parent hospital systems ERs, and that overcrowding should be shown to warrant expansion of hospital ER capacity. In other words, the system or the hospital has tried everything it can to address the problem, and so as an alternative to expanding the hospital emergency department or expanding it as much as they might, we would be willing to look at the alternative of developing a freestanding medical facility in their service area. And the other type of justification that we would look for, and of course this can also include overcrowding, would be a need for improved access to emergency medical care in the parent hospital or systems service area. So in short, I think we're proposing, and certainly we'll get feedback on this, that freestanding medical facilities not really be used as a vehicle for basically expanding your service area, planting a flag in the service area of competing hospitals through the development of these types of facilities. And hopefully we'll have a lively debate on that subject, or maybe not. We're taking a fairly conventional approach to structuring the draft plan that we're putting together. So you can see the criteria that we're using as an organizational principles here, and they're the criteria, with the exception of quality. They're criteria that you can find in our Certificate of Need procedural regulations as required considerations for any project, CO1 project review. So in terms of the types of standards that we're developing, as Kathleen mentioned, there's not a lot of consensus on quantitative, objective, threshold types of standards for use in evaluating the need for these types of projects, or other characteristics of these projects. So a lot of the standards that we're developing really fall, I think, within the area of outlining what types of analyses we want to see in terms of justification for these projects. So under the criterion of need, we'll be looking for a good explanation of the specific problems that the FMF development is expected to address. Again, focusing on overcrowding of existing ERs, or the need for improved access, We want applicants to really do a thorough and rigorous job of explaining what all the alternatives they've considered to address the problem are, and why they've landed on FMF development as the best alternative. They're going to have to give us a good understanding of their target population and what the historic trends and use of hospital ERs have been by that population. And we want to make sure that we account for the role of urgent care centers and other types of walk-in care options in these service areas, because clearly we do think that there's a spectrum, and there's certainly been a great deal of urgent care center development. Urgent care centers, I think you're probably all fairly familiar with that concept, although it's not as definitive a type of facility. There's a lot of different varieties of urgent care center, and they aren't a licensed care facility, so there aren't clear definitive standards that define what they are. But certainly what we see in other parts of the country is that we see hospital systems that are really developing freestanding emergency centers in conjunction with urgent care centers. So they're strategically looking at their service area and placing both of these types of facilities in an attempt to kind of create an optimal sort of access for different types of medical care problems. We'll also be asking the applicants to speak to insurance coverage of the target population and how FMF development fits in with the needs of the population and the capabilities of the population to get care. And there has been some development of some space and capacity guidelines, certainly extensively for hospital emergency departments, less so for FMFs, but there is some initial development out there, and we'll be looking at those types of guidelines and incorporating those into our state health plan. On the issue of access, we are going to look for analyses that show us how the FMF is going to optimize travel time access for the service area population. We'll be looking for the applicant to address consistency with the state health improvement plan for hospital EDs, and how the objectives of that plan will be assisted by development of the FMF. That plan focuses on reducing emergency department visits for 4 types of chronic disease conditions: behavioral health, asthma, diabetes, and hypertension. We'll be also looking for them to address the needs of underserved populations, and to tell us how we will be seeing improved care coordination in conjunction with these FMF development. So we don't want to create another facility where a lot of unconnected and unintegrated and fragmented episodic care occurs. We want to be sure that if we create FMFs, the operators have a plan for connecting the patients who present at these FMFs with ongoing primary care and care coordination suited to their conditions. Cost and effectiveness, as usual, that's kind of a basic framework for Certificate of Need regulation. So we're going to want to see a good examination of possible alternatives, again with a focus on what are are the primary care and urgent care alternatives available in the service area, in addition to hospital emergency rooms. Feasibility and viability will be developing standards on demonstrating that your assumptions are sound, that you have community support for the project, that there is an available workforce that you can tap for these types of facilities, and we're going to want to look at your use of process improvement tools and health information technology in FMF development. We'll try to use established quality measures for emergency medical care and incorporate those into the plan. And impact, obviously, we're going to be looking at impact on several dimensions. Impact on the parent hospital and parent system. And typically what we would be looking at in many cases would be a shift of ED care from the general hospital campus to the FMS. Impact on other hospitals, and impact on the cost of emergency care system-wide.
So our next steps, we're going to be posting a draft of the State Health Plan chapter for freestanding medical facilities. And we formed a work group, and it consists of representatives from the existing freestanding medical facilities, so representatives from Adventist Healthcare, Dimensions Healthcare, University of Maryland Shore, Regional Health. We have a representative from MedStar, various insurance companies, Aetna, CareFirst, HSCRC, the Maryland Health Association, MIMS, and the Office for Healthcare Quality. We don't yet have a consumer representative, but we're looking for a consumer representative. And we're looking forward to adoption of the new State Health Plan chapter in the fall 2015, and final regulations by the end of the year. And finally, we will schedule opportunities for application review in early 2016.
So I see on our slide that our first bullet point got hidden behind the famous Maryland Healthcare Commission logo. Didn't drop that down quite far enough, but that actually says posting for informal review and comment. So that will be the next step, and we do plan on doing that within the next couple of weeks, and we'll inform the Commission when that's posted so you can actually take a look at the draft.
Thanks for the presentation. Let's open it up for discussion, and maybe I'll just frame the first question. I think one of the arts in doing this is this whole issue about alternatives and substitutes, and if you and how high the bar will be set towards saying, has there been adequate effort to, look at less costly alternatives than that. So and that's a very much of a judgment call, especially in trying to translate this into regulation. So how are you trying to resolve that?
As far as having,
yeah. So here's the issue is that lots of the population, some people may look back retrospectively at their emergency use and say, well, they could have gone to primary care instead or urgent care, but they're going to emergency room, and so there's an ongoing need to educate and to change behavior. It never happens quickly. So the issue is if we proliferate here, we're just getting a higher cost solution, and so there's got to be within. When I'm reading this, it looks like you're going to establish some standards for looking historically where there are alternatives that tried to address the problem.
Correct.
And that's very much of a judgment call.
Right. Well, and one of those will be education. So educating individuals about the different alternatives. So that's one of the things that we will be asking these freestanding medical facilities to do some form of education about the different alternatives.
I think what we'll be looking for is any hospital that comes in here and says, well, my primary service area really needs a freestanding medical facility. I think they're going to be confronted with a plan that says, well, have you actually looked at the urgent care center model as an alternative to that? Something that obviously is a lower cost, type of walk-in service, but they're going to have to actually demonstrate that they have looked at that alternative. They looked at the cost. They've looked at the trade-offs in terms of the patient population that they can effectively serve with that model, and why, for a variety of geographic and other reasons. And obviously, they're going to have to bring in a lot of analysis of actually what's going on in terms of delivery of EMS at the hospital campus. Why is that not a cost-effective alternative for addressing one of the two problems that we're expecting them to identify as the basic reasons for developing this type of facility, which is overcrowding at their existing hospital emergency department, or in the case of systems, it could be multiple hospital emergency departments, or a real need for access. And quite frankly, you know, I don't think Maryland is a state where, at least from my perspective, there's that many places where a critical access problem is going to be effectively addressed by development of a freestanding medical facility. I think that clearly was the issue on the Eastern Shore when the legislature was asked to approve a second pilot for Queen Anne's County. If you'll recall, that facility has been in operation for a few years now, but is definitely a money loser in terms of, you know, being able to support itself, and probably always will be. I think the model that you're seeing out in Queen Anne's County may actually become part of the cost effectiveness analysis too, because, you know, clearly what the University of Maryland is trying to do there is create a larger outpatient campus in which the freestanding medical facility is just one piece. But, you know, there's been medical office development, ambulatory surgery center development. I think they're looking at other types of outpatient services that can be provided there. So essentially creating kind of the small hospital campus without inpatient services.
I'll go around this side.
So just imagining that this section of the state health plan or certificate of need was not added. Does that mean there would never be any freestanding medical facilities? Does that mean hospitals can do whatever they want? Does that mean, I understand the pilot program ends, and I'm very interested in the findings from the pilot program, and that the acuity at the freestanding medical facilities is lower, which certainly screamed urgent care center to me. But what happens without this?
Well, it's regulated under statute. So the statute is where it's established that you can't build one of these unless you're a hospital that gets a CON. So if we don't develop a state health plan, that doesn't mean people couldn't come in and apply for these. And what we would effectively be in that situation is we would have to make some sort of decision. You would have to make some sort of decision on that application, but you would not have developed any specific guidance for applicants or for yourself on how to reach that decision. And the statute envisions that that's how you make decisions on certificate of need. You don't just have general criteria, which is what you would have to rely on in that situation, that whenever there's a type of facility project that requires a certificate of need, you're expected to develop guidance through regulation of this type.
Are these rate regulated under the waiver?
They are rate regulated facilities. They did not initially start out. So Germantown, the first pilot, was not regulated in its first few years of operation, lost lots of money. But in 2010, they did come back when they created the second pilot, and at that time they decided to make these rate regulated facilities.
Okay, go on.
I have a couple of questions. One is a follow-up to the last question regarding rate regulated. So if it is a rate regulated facility and we're adding one somewhere, where does the budget come from? Where does their GBR number come from? Are we giving direction to the HSCRC to give them a budget? How are they going to get a basis for it? Any thoughts on how that all occurs?
I wouldn't say we're giving them direction. I think HSCRC has given rates to 3 of these. So they're operated. There's 3 operating as rate regulated
under the old waiver
facilities.
they did.
Pardon?
Under the old waiver they did.
Well, under the new waiver too. So just like hospitals in the past year, hospital systems that operate these FMFs have had to operate on. They're operating under a global budget, just like the hospitals.
No, I understand that, but the global budgets came from a history of the old budget, which was based on giving them rates based on their costs. Now they've got they all transitioned based on a history of what existed in 2013 to a GBR in 2014. These don't have a history.
They do, not much.
A brand new one can't have a history. So
well, they're not brand new though. Germantown's been around since 2006.
We're creating a health plan that will create the possibility for new ones in the future.
They were all rate regulated. Germantown and Queen Anne's, right from the get-go, from its opening, was rate regulated, beginning in 2010. So and Bowie has been around for a long time.
So we're never envisioning one that is de novo in the state health plan going forward.
No, we will, and they will have to address that at HSCRC just as they would have to address a new hospital. So if I give you an example, and this probably is actually kind of precedent setting in a way and would apply to these facilities as well. We had a new hospital open for the first time in many decades last year in Maryland, in Germantown, Holy Cross Hospital of Germantown. And basically what HSCRC did is it said, well, this is actually a second Holy Cross hospital. Clearly, even in the CON review, the patients that were foreseen using that hospital, a lot of them were patients who were otherwise using the parent hospital in Silver Spring. Not exactly a parent-child relationship, but you can think of it as a parent hospital. And so the global budget that was established for Holy Cross Hospital Silver Spring was reduced when the hospital in Germantown opened up. And they said, okay, we're expecting a significant shift. So, but then obviously they pretty much have to kind of see how will a new facility's utilization ramp up. And in updating the global budget each year, they're just going to have to address that volume growth and recognize that growth in the budget.
Second question relates to this question of why somebody can't just open one of these without a CON. So it sort of gets to that question of what's the difference between this and what's the critical difference between this and an urgent care center, other than the rates that you just other than the hospital rates. Where does that mark occur? Because you don't need a CON for an urgent care center. Where's the mark between a freestanding medical facility and an urgent care center?
I think rate regulation is, in essence, a critical mark. I think it's theoretically possible for someone to develop a facility that would be very much like a freestanding medical facility and call themselves an urgent care center. And if they can make it, if they can make it as a market price facility, negotiating with payers, good luck to them. I mean, I think obviously on Medicare reimbursement, that would be pretty tough because they'd be in the same situation Germantown was in their first few years of operation. Without regulation, when they saw a Medicare patient, they weren't getting any sort of facility fee reimbursement from Medicare. Their doctors were getting professional fee reimbursement, but that was it. And that's pretty tough.
And my last question relates to, you've talked about the sort of the opening of these new facilities or the upgrading of an urgent care type capacity to this hospital type capacity, but have you envisioned the request for a downgrade where you've got somebody who's got a freestanding hospital, regular hospital, and says, we want to close the inpatient capacity here. We just want to have a freestanding medical facility here.
There's actually a model that's been around on the books in Maryland for quite a while, and that's called a limited service hospital. So that was actually a category of healthcare facility created
about 1991.
So in the early 90s. Created but never used in Maryland, but it's there and ready for use. But it was specifically designed as that situation that you spelled out, a general hospital that wants to maintain an operation but without inpatient services. And there's been a lot of discussion of that because one of the requirements envisioned for that hospital in state law is a 24/7 walk-in service. So in many respects, people said, well, God, that's kind of like this other facility that you've now created, the freestanding medical facility. But that specifically is created for the purpose of becoming an alternative for a general hospital. And a general hospital who goes that route, if we ever get one, will not need a CON. They'll need a certificate of need exemption. They will have to get your approval, but it's a quicker and less onerous process. So similar to the merger of the hospices that you saw earlier today. Thank you.
Along the same lines, this whole market area, and when you talk on your project review standards, looking at alternatives, I know that's the alternatives for the parent organization in relation to the freestanding, or that's the way I interpret it. But this whole arena of, and it's similar, urgent care, episodic care, and all the different other varieties are now beginning to extend and blur in how they look with the freestanding, with full radiology capabilities and laboratories and all kinds of things associated with them. When this goes out for review, is there any standard definition that would support people making the distinction, and in the process of looking at the standards also make this distinction as part of an assessment of someone's interest in putting a freestanding? Because I have this image of a new kind of strip mall, and there'd be freestanding on one end, urgent care on the other end, a minute clinic in here and there, and as a consumer, I might not know which is the difference between all these new models, or there would be sort of an interesting pricing competition, which may not be such a bad idea, but it's happening in some neighborhoods and some regional states. So I just don't know if, when you're projecting forward to create this standard, whether some tallying up of the location against these other models and the definition of the models might not be an interesting, see what qualifies in which arena. And I don't know that there is any standard. Right now, I think it's in the eye of the beholder. So if I own it, I can define the scope of it, either regulated or not regulated. And I know there's some that clearly have to be regulated, but I don't think that is apparent to the consumer, or as you put this out there, of these hybrid models or these blended, things are starting to blend and blur a little bit in that arena, and give some consideration to that as you're looking forward at this.
We recognize that in order to properly regulate these, we are going to have to certainly increase our understanding of the options that are developing out there. And you're absolutely right. There is an incredible amount of development, a variety of development. Interestingly, we've seen Kaiser recently develop outpatient facilities that certainly appear to encompass all the characteristics of these freestanding medical facilities, but not licensed healthcare facilities, really not regulated any differently than any physician's office. And you see all kinds of things called urgent care in the state of Maryland, from a doctor's office, basically a single doctor operating in an office and pretty much seeing patients on a scheduled basis during the day, but then he stays open, he or she stays open a few hours later at night for walk-ins, and therefore they're now Dr. Smith Urgent Care Center, all the way up to, yes, very highly developed facilities that are approaching 24-hour operation, and are structured as part of corporations. So right now, this is going to be the model that actually requires licensure and CON regulation, and also, importantly, operates as part of a hospital and gets regulated rates like a hospital.
So it's difficult to make predictions, especially about the future, but I'll hazard to do so that these models, I think, were much more attractive before the advent of advanced primary care and the concept that primary care practices ought to be open evening and early morning offices. At that time, the urgent care model wasn't really wasn't financially feasible. There had a number of entities had tried it, including hospitals, and some had succeeded, many had failed. Provider offices had done that. But what I think has happened is there's been, in terms of urgent care, there's been an evolution, as Paul said, is that we're a primary care office that happens to be open 18 hours a day or longer in many instances. The model at Patient First is evolving that way, where they initially, with many payers, were in network for urgent care only. I believe Commissioner Flagg can comment on this, but now they're in network for both primary care and urgent care. They follow the same pathway, I believe, at Care First. And I think the attractiveness of it, and even perhaps the need for this model, is not as great as it was thought to be in the 2006-2007 period, where you could see these developing. I think, having been to the Queen Anne's facility a couple times under cover of darkness, I can say that it's a pretty impressive facility, positioned as it is, fairly far away from a full acute care hospital, and perhaps this model does work in rural areas where a acute care hospital wouldn't work. But I do think that they've finally gotten the medicine right for urgent care, which is a combination of primary care and after-hours care, either from these new models, these new ventures, or from evolving primary care practices. I would note that Patient First has continued to be successful. What's impressive is the evolution and pretty rapid diffusion of the MedStar model, the prompt care model, which is now being, that footprint is growing across the state in a similar way to Patient First.
Any questions or comments on the phone? None. Diane, one last question.
So that was very helpful to hear a bit of background on that. And I go back to the question of if this additional chapter were not added and a hospital wanted to create a freestanding medical facility, they would come forward with a certificate of need request, correct? Would the commission, the staff and the commission, have the ability to ask questions and pursue information regarding the availability of alternatives such as urgent care centers and other services?
I think we would be free to ask, whatever questions we deemed appropriate.
Thank you.
But we don't know what kind of application we'd get.
So it sounds like there's a fair amount of work, and then there's going to be further touch points around this going forward. Thank you very much.
Okay.
On to agenda item number 6, results for the state EHR incentive program. David Sharp and Angela Evat are going to present on the results of the state EHR incentive.
Good afternoon, Mr. Chairman, members of the Commission. We're excited to talk to you a little bit this afternoon. Angela will really do most of the legwork. I'll sort of tee it up and answer questions as well with her. But it's interesting to note that this program really hit the ground running in 2009. And the thinking was then that the Meaningful Use program was, in and of itself, was not going to be enough to create a tipping point. Some may say, well, Medicare's for eligible providers is 44,000, and Medicaid was up to 63.7. But in reality, there's a model around how those payment calculations are done. It's on a per claim basis for Medicare. Not every physician is going to meet the threshold requirements for Medicaid, and you can't participate in both. So this program offers an interesting way to help primary care providers, nurse practitioners, who may not have enough incentive, but in and of it alone with the Medicare, Medicaid program, but adding in the state-regulated payer program will help them go through the arduous steps of implementing technology, which can be a burden for the physicians around the table who have done this, and it can help with the transformation of these practices to use the technology. So with that, let me turn it over to my colleague and let her get started on the presentation.
Thank you, David. Good afternoon, Commissioners. I'd like to start with some background information about the State Incentive Program for those that aren't as familiar with it. A law enacted in 2009 required the MHCC to develop regulations that required state-regulated payers to offer incentives to providers as a way of increasing EHR adoption and use. The law was, the framework for the regulations were developed with our work group, and the regulations went into effect April 21st and were slightly amended thereafter on October 21st, 2011. At that time, EHR adoption was relatively low. Office-based physicians were out at 19%, and nationally we were at 22%. Some of the key provisions of the incentives are that primary care practices qualify. These include family, general, internal medicine, pediatrics, geriatrics, and gynecology. In order to qualify, they must also adopt the certified EHR within their practice. And the 6 largest payers participate in the program. These include Aetna, CareFirst, Cigna, Coventry, Kaiser, and United. This is a one-time payment from the payer to the practice, and that's for each payer that the practice does business with. And the incentive is calculated up to $15,000, and it's based on their practice panel of $25 per patient for that practice. In order to qualify, the practice must also attest to meaningful use. This is under a program that was implemented under the American Recovery and Reinvestment Act, and the Meaningful Use program began in January 2011. Under that program, eligible professionals can receive up to $44,000 under the Medicare incentive, and a little bit over $63,000 over 6 years on the Medicaid side, which ends in 2021. The meaningful use requirements become more stringent over time for both eligible professionals and hospitals. In terms of those eligible professionals that qualify, this slide gives you an overview of who those folks are. So in 2013, staff did an assessment of the incentive program to ensure that it continued to meet the intent of the law. The findings from that assessment indicated that the program was essentially a rebate program and was incentivizing the adoption, but not necessarily the use of the system. And the program was a bit misaligned with the federal incentives, which created some operational challenges for the primary care practices. We also noticed at that time that the participation in the state incentive was far lower than that of the federal incentive. The state incentive, we had 4% of eligible primary care practices participating, while on the federal side it was 29%. So given this, the regulations were amended. That went into effect on June 9th. Some of the key changes were, as I had mentioned, that practices must first reach meaningful use in order to qualify for a state incentive. And then we also added an alternate to that because we knew that some primary care practices would not be able to qualify for meaningful use. They might not meet the patient threshold. So the alternate is that the primary care practice can meet be in a PCMH program and achieve NCQA recognition. We also streamlined the administration of the state incentive program. Previously, it was sort of a two-tiered where you would have to apply, wait a few months, and then submit a payment request. We did away with that, and it's only the payment request. We also clarified the definition of primary care practice and extended that to nurse practitioner-led practices for the incentive. And finally, we extended the sunset date to December 31st, 2016, by 2 years. Given those program changes and what we knew about participation, we implemented with our partners at MedTi, DHMH, CHRIS, and the Maryland Nursing Association some targeted outreach activities to increase awareness of the new provisions as well as just the incentive program itself. We targeted primary care providers that we knew had registered or attested to meaningful use and reached out to them via fax, email to encourage their participation. We also reached out to individuals who might have contacted the Meaningful Use Help Desk, which is operated by CHRIS, where folks will get information about participating in the meaningful use, and this is a great opportunity to reach out to them about the state incentive. And then we also worked with our management service organizations who are sort of a boots in the ground and working with practices to achieve meaningful use. So this graphic here shows our rate of increase in terms of EHR adoption among office-based physicians. As you can see there, we've experienced about a 30% increase since 2011, and we're about 10% ahead of the nation in terms of adoption. In terms of the state incentive program, since October 2011, approximately 370 primary care practices have received an incentive, and this is totaling over $8.3 million. Participation has increased since our last assessment period by about 14%. What we're also seeing is that the average number of applicants that result in a payment has increased by 10 per month since the new provisions have been in place. So this graphic shows among those eligible primary care practices how many have received the federal incentive. So we're showing about 660 primary care practices have received the federal incentive, and that means at least one physician or eligible professional has received an incentive within that practice. And among those, 253 have received a state incentive. So that means that 38% of eligible primary care practices who have received the federal incentive have also received the state incentive. And we've seen that increase since our last reporting period by 27%. So that being said, we plan on continuing to work with our partners to target outreach to those who have reached meaningful use. So that's specifically those 407 practices that we've identified who have received a federal incentive but not a state incentive. And we also want to increase awareness about the Meaningful Use Program among those 12,000 practices who haven't received either. Additionally, we plan to explore the impact of extending the state incentive beyond 2016.
Any questions?
All right, thank you. Any questions or comments? Adam.
Hi guys, thanks. Any thoughts about extending the program to non-primary care physicians?
That's a good question. Thanks for that. In statute, there is not a sunset provision. We added it to the regulation because what we wanted to do was at some point in time look at it, determine if did it work for primary care? Are we at capacity? Could we look at expanding it to other provider types? And then really come back with recommendations. So I think the break at 2016 is to say this. We think we've done what we can here, and now it's time to look at and see if there's anything else that can be done. So the very quick answer is something to contemplate.
David, in terms of the physician response to all of this, have you had any indication, have you done any kind of surveys on how physicians are responding to these requirements and these incentives? Do they feel that the use of the meaningful use standards are something that improve medical practice or the quality of clinical care?
So, Dr. Moffat, thank you for that. We're in good company because enough physicians are around the table that could weigh in on that. But anecdotally, the reviews are mixed. I mean, they're clearly mixed. I think a lot of physicians struggle with the burden of meeting the meaningful use requirements. It's a tall bar to meet, and so many practices have just continued to struggle to meet that. And keep in mind, if they meet one stage, and stage 2 comes in, and now in 2017, stage 3 comes along behind it. I think in Maryland, physician practices, physicians, hospitals have done an excellent job in staying ahead of all the challenges. That's not to say they're there and they've figured it out. The incentives help. They make what one might refer to as a bitter pill a little sweeter, but I don't think in any place any physician can say, yeah, the meaningful use program has made the difference for us. I think it's going to take, that answer is going to take a lot longer to realize.
All right, but what you're saying is that right now, the evidence on the ground is that at least among physicians, there is a very mixed response to all of this. And there is no consensus among the medical profession that this is improving patient care. Is that correct?
I think that's a fair read.
That's a fair read.
Yeah, I think, and I would look to my commissioners here who are physicians to indicate whether that's a correct read from staff.
I'll add, since you're opening up to the doctors, my 2 cents here is I think that level 1 seemed pretty reasonable in terms of just trying to get interoperability. But when you got to 2, I don't think the state of the art around workflow and what actually was value added to the patient, to the doctor, and everything was really thought through, and so it was much more from the system needs. So I think there's a significant minority, if not majority, of practices who really struggle operationally with higher costs as a result of this, of which the incentive covers some.
Yeah, but higher costs, there, as you know, Mr. Chairman, there are no higher costs for physicians that do not find themselves into the bank accounts or the pocketbooks of patients. There's no economist on the face of the earth, as far as I know, who thinks that anyone other than 100% of households pay health care costs. So the question is this actually in a cost-benefit way? Is this actually improving either healthcare cost or the quality of care? And what you're telling me, I guess, is that the jury at least is still out on this. Is that correct?
Yeah, as a matter of opinion, I would say yes. I think there would be the policymakers of the federal government, the former coordinator for O&C would probably disagree with me and say absolutely it's making a difference. So whatever it's worth.
But maybe if I might add one other point in terms of value is if you said a value from patient care, let's be really simple, is eye contact with the clinician and establishing the relationship. There's pretty good evidence that the establishment of EMR has decreased that substantially because you have the clinician spending more time looking at the keyboard than they are at the patient oftentimes. So, yeah.
Just a very quick question. I apologize if I missed this. Where does the money come from to pay the incentives? Is that part of the commission's budget? Or?
So the funding mechanism is from the state-regulated payers. They're actually funders. So when a physician practice meets the eligibility requirements, they send an application to the carrier processes it through and makes the payment. So it does not come from not state dollars or MHC budget.
Wait a minute.
Thank you.
Sorry. Excuse me.
I made it okay.
No, it's
all better.
We got to follow the money here. So what you're saying, the insurance companies.
The insurance company.
Okay, so we're paying it in our premiums.
Yes. You're paying
okay. Just want to make sure I'm clear about it.
You're absolutely clear on that.
yeah. Okay. Any questions on the phone?
Yes, Ligia Peralta has a question.
Go ahead.
Thank you. In following the question about what is the benefit for the patient, what this is bringing to the patient, I'm wondering, since the private sector is funding this, if there is any data that they can provide to us to be able to inform us a lot better about what is going on and what they are detecting at this point.
So I might offer up a suggestion before others. I think there's just not enough data yet to be able to provide a definitive answer like that. And maybe Commissioner Flagg might have other thoughts about that.
I do not.
I just need to say something here. I am not a physician, but I think that there are different levels of looking at meaningful use and looking at what the purpose is. There certainly is critical need for the individual physician-patient interaction, and I am a huge proponent of patient-centered care and better engagement with patients and better relationships between physicians and patients. So I do not mean to discount that at all. At the same time, the availability of data in electronic format is a fundamental underpinning of what we do, in terms of quality measurement, in terms of assessment of quality, in terms of public reporting, in terms of transparency. So while it may be a pain in the neck for certain people to shift their business model to use technology to enable data to be collected and shared and do it in a meaningful way that information can be used, that it is part of the change that's difficult. It's a cultural change. I think it's myopic to only look at that and to say, is there value or is there not value? Because in some ways, it's like, you guys, look at what we do here. What we do here is dependent on the availability of the IT infrastructure and the availability of data in an electronic format.
Great discussion. One last point.
If I could just answer that. If you were to design a prospective study in any way, shape, or form in which you decided that you were going to collect every piece of data available and use those pieces of data to try and answer questions that you hadn't yet asked, nobody in the world would fund your study. It's a phenomenally inefficient way to do science, and that's what you're trying to do when you ask the primary care physician at the front end to collect the data for you about questions you haven't asked and you haven't vetted in a peer-reviewed format. That's not how science occurs. If we want to ask specific questions prospectively, we want to vet those questions in the methodology prospectively, define exactly how we're going to collect that specific data, and ask the primary care physicians, even the specialists, to collect that data prospectively in an electronic format, that's fine. That's not ridiculously expensive. That doesn't cause you to collect data that you're never going to look at. Well, we look at a small portion of the overall data collected. And it allows you to do something that's cost-effective, that doesn't unnecessarily disrupt the interaction between the physician and the patient. It's not what's happened here in meaningful use. But we've decided in these electronic medical records, we're going to collect everything electronically, prospectively, and then afterwards we'll decide what questions are important. That's not the way science is done. It's the way you do things when you really don't understand what you're doing.
The other piece, though, I'd say there's a large consumer interest in access to their medical records in an electronic format. And if only certain pieces of the electronic medical record are collected, then it's difficult or it's impossible for consumers to access their data as well. So there are all I'm saying is that there is more than one purpose, and there's certainly more than one stakeholder involved in interest in what comes out of the collection of data or turning data into an electronic format.
What I appreciate is after this group meeting this must be the 7th hour, not 8th today, we're still having a high level of engagement. So this is great. But I think in the interest of time, I'm going to wrap this up. We are going to, thank you very much.
Thank you, Mr. Chairman.
We are going to defer item number 7 to another time. And we're going to end, last but not least, on the evolution of the small group market, where Bruce Kozlowski, who's co-director of the Center for Quality Measurement and Reporting, is going to discuss the status of transition of Maryland's small group health insurance market. Bruce?
Yep, who magically pressed the button. So anyway, Mr. Chairman, Commissioners, pleasure being here this afternoon. I sat back there saying, will he just cancel mine so they can go home and have the others speak? But it didn't work that way. But if you don't mind my digressing for a minute, I would be remiss if I didn't respond to a question that Commissioner Phillips asked that was partially answered, not completely answered. You asked the question, where does one get the data on nursing homes based on their inspection outcomes? And the answer is you go to MHCC's Guide to Long-Term Care, and you press the button, and for each nursing home, the information is there, both current and retrospective. Okay. Thank you very much.
Yes, you should have, Commissioner.
Alrighty. So anyway, this is, if I can get it to work, is going to be quick. That's not the way it works.
Linda.
Yeah, thank you. Which one's fastest here?
Linda, why don't you just help?
I'll sit here.
There you go.
Stop.
Good lady. Let's go to, there we go. So anyway, the Comprehensive Standard Health Benefit Plan was established really a long time ago, and Maryland, in a lot of ways, was very visionary about the need to have a program for small employers who had a history of struggling in the context of finding affordable care for them, for their employees. And so they put this program together, I think back in early 90s at some point. But that being the case, the benefits and cost sharing were developed and modified by both the MHCC and the Maryland Insurance Administration. We had joint regulations, which was kind of interesting when we wanted to change regs, working between two organizations. It includes most of the broad categories of services that are required as essential health benefits under the ACA. Again, they were very forethoughtful in what needed to be there as a package of services. They had inpatient, outpatient, the usual pieces, and prescription drug coverage, which we'll tap on later a little bit. Mental health parity and pediatric dental are not quite the same as the ACA requires. The comprehensive plan also requires coverage for several legislatively or commission-mandated benefits, and that shouldn't surprise you in the political world. But one of those that the commission actually pushed forward rather than the legislature was bariatric surgery. When the statistics started showing that to be a very positive solution to a difficult problem, the commission went forth with that recommendation. It excludes in vitro, and just go to the next slide. So along with that was a subsidy program called the Health Insurance Partnership. And that was a very successful piece that we ran in concert with the small group insurance plan, established it back in 2007. The employers could not, in the previous 12 months, have offered insurance. We didn't want people being able to pop in and pop out when they had in the old shoot and run game. And they had to have at least 2 and no more than 9 employees. We were looking for the smallest of the smallest, because the budget for this program started really big at the beginning of the legislative session and got to be really small by the end of the legislative session. Has not offered a small group policy to its employees. That's redundant, I said that. And the average wage of all employees is below $50,000. So we were looking for that really small core. The employer had to make contributions that were at least high enough so that 75% of the full-time members were interested in getting coverage under the plan. And the premium subsidy program, of course, as the ACA came in, we closed it to new groups effective January 2014, and then we gradually phased it out. There were certain challenges in the development of the exchange, and we didn't want to leave small employers sitting out cold until there was another system in place in order to provide subsidy assistance of a sort. And so as of May 1, 2015, there will be no new enrollments. Participation, this is an old slide. In assessment, I grabbed a lot of old slides from old presentations, but just wanted to show that in 2013, we had about 38,000 groups that were participating in the comprehensive plan. And the number varies a little bit depending which agency you talk to, but that represents about 37, 38% of small employers in Maryland. And so it never, never reached up into the high numbers. And as you can see by the numbers, the 337,000 lives at that point in time. And then the next one has to do with the shop exchange and its transition. And this is really kind of fascinating, especially if you've been involved in it. But as I said, there were some challenges in the launch of shop, launch of the exchange, and shop was delayed. The TPAs are kind of unique to Maryland, the third-party administrators. They have contracts with the carriers, and they do much of the processing of getting people enrolled and into the healthcare plan. So the TPAs were authorized via waiver to act as kind of the shop at that point in time to deal with providing these subsidies. And the shop uptake, as you can see by the numbers, was relatively small because most of the plans, most of the employers had previously been buying their insurance on the outside and didn't see an incentive to want to go through a new methodology when there was an effective process in place. And so in July of 2014, the exchange decided to put out an RFP and ask essentially the TPAs in Maryland to put forth proposals to, in essence, become over a 3-year period the complete requirements, coming up with the complete requirements of a shop exchange. And the real challenge there is there wasn't much money to do it, so there's a very, very small amount of money available to them. 3 of the largest TPAs stepped up to the plate and put forth proposals. And I think in the wisdom of the exchange, it was in the best interest of Maryland to allow all 3 TPAs to participate. And very definitely in that context, if you had one and one popped out, you'd be back to this whole process of trying to create a whole new environment for this small group. So using the 3 TPAs was economically savvy decision because the infrastructure was already in place. It's used by the carriers. It's been very efficient and definitely less expensive than building a federally certified shop. Allows Maryland to meet the shop requirements without a significant state investment. As Ben has indicated, the exchange is already looking at some challenges there. And the problems in 2014 with the individual exchange gave the MBE time to scale its approach based on slow shop uptake in other states. So it's not unique to Maryland that shop has not been overly successful. This next slide, next slide I just threw in just to give you a feel for what the base rates were in the comprehensive plan. Employers had the opportunity to buy riders, but the riders had to be positive riders. They had to be buying down co-pays, deductibles, etc. That's just base. That's only there for quick reference. SHOP has unique offerings. There are tax credits available in the SHOP for small employers. And few employers, however, I think you've all read the literature, utilized it, because if you ever went to the federal site and you looked at what you had to do and you looked at you were going to get something after the fact instead of before the fact, and you didn't have discretionary income to start with to be buying a healthcare plan, you just didn't go forward. And so employee choice models are available in SHOP.
that would allow employers to pick certain middle-level plans from several carriers, and employees pick among the plans. But that also creates some real challenges. Small employers have not been enthusiastic because usually the small employer is the CEO, the president, the treasurer, the human resource person, and is also the one that generates the revenue for the firm. And so when it gets to be complicated, it gets to be problematic. And too many choices, I'm really a proponent of that. We did that with Virtual Compare when we were doing small employer on our own website. Too many choices sometimes makes it difficult to understand the options and to make an informed choice. Brokers aren't too happy about employee choice because brokers like a very easy path from last year's sale to this year's sale. And when you make that much more complex, they're not too happy with that either. And as I said, the small employer prefers to keep it simple. Do not anticipate that that's going to be a big thing anytime soon. So what are the trade-offs between the comprehensive plan and SHOP? And this may seem a little bit convoluted, but we're flipping between two time periods in essence. In 2014, small group moved from composite rating to member level rating. And in the past with the comprehensive plan, employers were off a premium based on the composite rate for all their employees. Really easy to figure out what you were going to do in your contribution. Under the ACA, each of the employees and dependents are age rated, and then the cumulative rate is offered to the employees. So you've got different rates for each of your employees. Under the comprehensive plan, the family premiums were calculated based on the average number of children. Under the ACA, each child in the family up to 3 is individually rated. So again, there's a greater complexity in that process. All insured children over 18 are also individually rated. These rating rules have raised rates for large families and reduced rates for smaller families. The comprehensive composite rate was consistent for all employees. So, however, it raised the rates for older employees and lowered the rates for younger employees. So there's not a perfect world out there. We haven't found a silver bullet. Small group market moving forward, this has been kind of a fun piece because I think when you look at one of the issues is use of limited networks to control cost. 3 years ago, it was a really hot topic. We need limited networks to control cost. And then you've got the proponents on the other side going, wait a minute, let's talk about access. We need more people out there for more choice, more accessibility, and that's something that's going to have to work out over time. The small group products will increasingly have higher out-of-pocket costs, which results in a cohort of insureds avoiding care except in catastrophic situations. And some of the deductible levels and out-of-pocket costs are, in fact, making people think twice about using their services. However, there are some creative plans out there that will expand the range of pre-deductible services that may prevent future high costs like lab services and for geriatrics. So I know that currently is in the works. Some opportunities for plans due to changes in the market. We've just watched Evergreen as Evergreen has creeped into various components of it, starting out in small group, in individual going to small group, and now doing marketing in individual, small group, and large group. Small group moving forward, small business shop and exchanges must open up to businesses with up to 100 employees in 2016. Never was a big proponent of that, but I don't think what I feel has anything to do with it. It's likely going to happen. But the reality is most firms, as they approach in size, around 75, start to become self-insured anyway. And so the amount of change that's going to occur, I'm not sure is that great. The expansion could disrupt small group if larger firms with negative records decide to join small group, and firms with young and healthy employees
decide not to. Again, we're dealing with a pool, and that was one of the major issues in the whole design concept to the ACA. There's greater use of self-insurance in groups, as you said, to 75. And one of the things that came into play, I believe 5 years ago, time has gone quickly, but was the use or marketing to very small employers, some as small as 5, to become essentially self-insured by using stopgap. And Maryland took that to court, thinking that was not a good approach, and lost in court summarily. And the concern has continued, and so legislation was passed this year that requires for existing renewals that take place in 2015 that the attachment point be not less than 10,000 and the aggregate attachment not less than 115,000, 115% of expected claims. After, with all new claims this year, that's going to go up to 22,005 and 120%. Maryland Insurance Administration will also concurrently be conducting a study to see what the impact is on those changes and on the small group market. In previous MHCC report, which I was so happy to find, estimated that 15% of the small group market uses the stop loss option. And so not exactly sure that with these changes that took place in legislation this year, that there's going to be much growth in the use of stopgap. Trends and possibilities for small employers. Percent of uninsured has declined in Maryland. And that's very positive. Possibly in the future they will do reform the offerings with broader tax credits and less complexity, which would encourage employers to take use of that and further decline the uninsured. Designating the 3 TPAs as a proxy shop in Maryland is anticipated to stimulate an increase in shop employer groups and employees. Whether it does it inside the exchange or outside the exchange is unimportant. It's the fact that the employees get insured. And ACA is like any other insurance plan, any other product that carriers bring out. It has to mature. And I started with Medicaid in the beginning, and I believe it took about 10 years for Medicaid to get into puberty, another 10 years for it to get through adolescence, and then 30 years out that it finally got into maturity. By the way, its birthday was last month. It turned 50 years. And in that period of time, there have been all kinds of changes in which predictions fell far short of anticipation, and in other cases where hopes were much greater than anybody ever expected. So the ACA is going to have to mature before you can become very confident about what's going to happen. But looking at the stats of what's been filed with the MIA for this year, there's been in small group market, because most of the press you read, about 35% is in individual. The dominant carriers requesting 17% reductions in 4 of its plans and 3% reductions for 2 of the plans. And most other carriers' adjustments are minimally 3 to 4% increases, with one carrier requesting a 15% increase for its 2 plans. And that, Commissioners, is the end of looking at history and present and a little bit of going forward. And I very much appreciate your time and attention. Thank you.
Thanks, Bruce. Any questions or comments? Anybody on the phone? Not? Ben?
I was just going to observe, as we 2 years ago passed the authority to administer the small group market. We did it with basically 1 employee, which, given cost of some of the federal programs, seems daunting. But our ability through the all-payer claims database to monitor the small group market will continue. We will be sharing information with the exchange as they go forward, and I think now, we haven't seen significant changes in small group based on largely anecdotal data we've seen from 2014. It was very much steady state, but although our authority to define the benefit package is gone, our interest in studying the small group, I would argue, should continue. It's an important segment of the Maryland market. Certainly, it's a known cliche that small business is the engine of growth, and certainly the status of that, of individuals seeking coverage through small employers is something that should be a concern to the Commission.
And I would just want to offer, if Janet Ennis, who happens to be in the Deep South right now, was here today, she'd be sitting next to me because she put a lot of effort into the small group, and very much appreciate all the work and effort that she did during that period of time. So again, thank you very, very much. Appreciate it.
Thanks, Bruce. All right, Ben, do you have an overview of
so in
upcoming
recognition
initiatives?
of the clock stopping at 4 o'clock, I can say there will be a Commission meeting in July. It will be will include items similar to what you've seen today, and I'll leave it at that.
Okay. If there's no other business for the Commission, I'll entertain a motion to adjourn. All right. All in favor?
Aye.
Meeting adjourned.
Thank you very much.